The expert tibial nail is indicated for fractures in the tibial shaft, as well as for metaphyseal and certain intra-articular fractures of both the tibial head and the pilon. These fractures are 4-1, A2, and A3, 4-1, C1, and C2, all 4-2 fractures, 4-3, A1, A2, and A3, 4-3, C1, and C2, and combinations of these fractures. The main objectives of this presentation are to show the patient positioning, reduction, the approach and entry point, and the procedure for nailing using the expert tibial nail. The expert tibial nail can be inserted into the medullary canal either with or without reaming. In this presentation, reaming will be demonstrated. The nail will be inserted over the guide wire. Shaft fractures will be introduced. With simple shaft fractures, 4 medial lateral locking screws are normally sufficient, 2 distal and 2 proximal. Secondary dynamization is achieved by removing the locking screw from the static locking option. In very proximal and distal fractures, additional interlocking is required. The patient is placed in a supine position on the radiolucent table. The knee of the injured leg has to be able to be flexed at least 90 degrees to 100 degrees. The image intensifier is positioned so that visualization of the tibia, including both the proximal and distal articular surfaces, is possible in the AP and lateral views. A leg holder may be used to help for reduction, surgical approach, and insertion of the nail. The knee roller has always to be placed under the lower thigh to avoid neurovascular compromise in the popliteal fossa. The closed reduction is performed manually using axial traction under image intensification. The reduction can be temporarily fixed with reduction clamps. The required nail length must be determined after reduction of the fracture. The image intensifier is positioned for an AP or lateral X-ray of the proximal tibia. Using long forceps, the radiographic ruler is held parallel to the tibia on the lateral side of the lower leg. The ruler is placed so that its distal end is level with the required nail insertion point. The skin is marked on the lateral side. The image intensifier is moved towards the distal end of the tibia. The proximal end of the radiographic ruler is aligned with the skin marking, and an X-ray of the distal tibia is taken. The reduction is verified, and the required nail length is read from the radiographic ruler as it appears in the X-ray. The image intensifier and radiographic ruler are also used to establish the appropriate diameter of the nail. The entry point is decisive for the position of the expert tibial nail in the medullary canal. This position is most important for correct fragment alignment of proximal and distal metaphyseal fractures. In the AP view, the entry point is in line with the axis of the medullary canal and with the lateral tubercle of the intercondylar eminence. In the lateral view, the entry point is at the ventral edge of the tibial plateau and in line with the medullary canal. The guide wire is secured in the universal chuck with T-handle. At a 10-degree angle to the shaft axis in the lateral view, the insertion point is lightly punch-marked. The guide wire is advanced approximately 8 to 10 centimeters